support, that, you're just left out to sink. It's just, they just haven't found the right fit for somebody that is able to go, it's like you have to have them tough conversations.
Yes, absolutely.
You have to start at the basics. Like I always say, when I was a DON or when I was a unit manager, and you have to take charge of your unit. It's your unit, be the leader.
Right.
And starting at the CNAs, I would always, when I would hire CNAs, when you walk out of that room, that reflects you.
Right.
So when I walk down the halls and look at units, that reflects that manager that's overseeing them and holding their staff accountable.
Yes.
To make sure that it's looking presentable, to make sure that, the ladies are shaved and the guys look clean and nails are clean. And just now people struggle with wanting to tell people, you know what? Why aren't these, why do these ladies have facial hair?
Right.
And if it's a problem, I have no problem cutting nails. I have no problem cleaning nails. Let's get down to the source. We got to fix it.
Right.
But first we got to get it done.
Right. Exactly. So
that's kind of been the struggle there, is just having somebody that will hold that accountability.
Uh-huh.
It's been, just staff wanting to stay on their cell phones, and they look at you like you got four heads when you tell them to get off their cell phones.
Right.
Just things like that. And it just makes a big difference, in resident care and how the halls look and rounding and, just the reminding we are there for residents.
Right.
We work in their home. So nobody just really wants to stand up and take that ownership. We've had trouble finding people that'll do that.
That's something I currently deal with now in the building that I'm at. So it's it's almost like a broken process I walked into with walking into Talis. I'm not really trying to downplay. I'm not trying to talk bad about my current, I'm not trying, but it's like walking into a broken process and, finding things that's already broken, and you're kind of just managing how to go through that process, and it's like seeing where the faults are, and you're constantly, and me being the lead nurse there, and it's like I'm constantly finding myself going to management, and there's like, oh, we'll get to it. It's like, when are you gonna get to it? Or consistently like having short staffing where my aides are running faster than me, and it's like, I advocate for my CNAs because it's like, and they're like so tired, and it's like, and I have to tell them, pace yourself and just do the high priority stuff. The low priority stuff, don't worry about it. It's a staffing issue, not a performance issue, so it's not going to fall on you. So I have to advocate for them, tell them to pace themselves. And as their charge nurse, I feel like it's my duty to advocate for them. And with other nurses, I don't feel like they're advocating for their aides, and I feel like for me it's unfair. I always have to stand up for my aides, and I'm consistently finding that the aides that are not even under my unit, they're coming to me because you're the only one standing up for us. How come they are? It's like, I can't speak for that nurse, but for me, I used to be a CNA. I started out as a CNA. So I know your workload. You are the backbone of what we do. You have eyes on our patients more than we do.
Right. Yeah.
So if my CNA says...
you can always tell nurses that have been CNAs. And I feel like the struggle is the nurses don't really take ownership of, the CNAs, and they can't even tell you half the time when they're on break or where they're at. Or I find that's also a constant problem that we have there too. CNAs constantly like to go in groups on break, and it's like, you can't do that. You can't do that. Yeah. So that's kind of, I think, the biggest... there, you'll find plenty of problems. Like I said, it's not a perfect area you're walking into, but it's very doable, and you have the support. You're not just kind of thrown out there to swim on your own.
Right.
Staffing, they're pretty good with their staffing numbers. Of course, if you ask any CNA at any given time, they're always short.
Right.
But, like I said, it's one of them buildings, and I don't know. Have you ever worked with Medilodge before?
I have not worked with Medilodge before. I have friends that have worked in Medilodge in the past, yes.
Okay. It's, Medilodge has been one of, and I've worked with a few different companies before. I think I'm going on a year with them right now, but Medilodge is not bad staffing numbers. You're actually kind of spoiled. And what like the nurses, there's, four, like for that building, 4 floor nurses, a treatment nurse, you got an IP nurse, so it's like nurses don't even have to do their own treatments.
I know, which sounds like really spoiled. I mean, you basically, all you have to do is concentrate on MedPass, talking to the doctors, new orders, your assessments, and what else do you have to do? I mean, that you don't have to do treatments, you don't have to really do a lot much except manage your own floor, so what are you doing in your downtime? Yeah, and it's still struggling. So what are you doing with the rest of your time, and how is it such of a struggle? So whereas in other buildings, yeah, exactly. With other buildings, you're having to wear like 4 or 5 different hats, and it's understandable maybe why things aren't getting done because you're wearing so many hats. But with here, if you don't have to wear many hats and still not getting done, okay, what's going on here? Why are you not still getting things done?
Yeah. And that's, and that's what they need to get down to, and what they, I think just having consistency and getting, knowing, and in the aides, I filled in there as a DON right before Jesse came, and the aides are they're open. They're very, it's like they're not, they don't just like go against everything you say. They're very open to the communication and to changes. But I think it's just they've seen so many come and go. They just don't, this one's not gonna stay, and they're not used to that.
I see that. Yeah, that's also the same pattern. It's like they say something to management, and then management says one thing. It's like, well, and then that management position leaves, or they resign, they go somewhere else, and then and then a new management. So then what their complaints go on to new ears, so nothing gets done. Pretty much, it doesn't get resolved. So I kind of see on their end too. It's like, what's the use of complaining when nothing's being done? I see it on their end too.
And then they don't trust.
Right. Yeah, there is no trust. Exactly. I feel them too. It's 2 ways.
Yeah. So I think just getting somebody that's willing to work with them, and they're in their survey window is May for their annual, so they are coming into their window here shortly for their annual. Have you done management in the survey role?
I've done management and survey role, yes, and it tends to be chaotic on management side, but I've been a floor nurse, I've been followed by state, I've been asked by state so many different questions, pulled sideways. But as management, I think I've only been with management once when state was in the building. So
yeah, no, and it's I just like to ask. I mean, it's changed so much over the years. It used to be they would put management for questions, and now they try to avoid management and go right to the floor staff to get their answers. And they've had they've kind of struggled, like I said, in the past with their surveys, but once again, that's been due to all the turnover in the positions. So Valerie seems to be like, she's going to be really good. She's new there. Jessie, I've worked with her since May, and she came in, I think she was there like 4 days, and then annual walked in. So we got to know each other really well because we had like 19 tags.
Oh, wow. Okay.
Yeah, so it was a rough one. But honestly, a lot of the tags were stuff they seen during that survey. Like floor mats not down. Okay. What else was there big? Enhanced barriers not being followed. So it wasn't that they went back and dug on a lot of stuff. It was just the stupid, inhaler not having expiration dates. Okay, yeah. Med air. So it was all stuff that they seen right then. So it wasn't.
Oh, so that's stuff that they actually caught on scene and on spot.
Yeah. Okay. Yeah, the majority of it was. So we got through that, and so we'll be coming back up on their annual. They've had a few complaint surveys, nothing major. I think their last one, we got a care plan tag. So it wasn't anything huge. Any questions you have for me? I mean,
I'm just actually looking for like how many current unit managers are in Westwood?
Currently, they have 2, so
Okay.
you would be the third.
Okay. And would I be managing my own unit? And would I
Yes.
be okay? And do you know right now which unit that would be, or not yet?
Don't know how she's splitting it. I
Okay.
apologize.
No, that's okay.
Yeah, their rehab hall is D hall, and that has, I think, only 16 patients on that.
Right, and I think I asked her that there's only 16, and it's split with the longer hall, which has 30 something. Yeah, I think she had mentioned that before. Yeah.
Yeah. So nope, we want you to have your own unit, and that way you can take charge. Medilodge has pretty much everything laid out for you. Everything, there's not they pretty much, as long as you follow like their, I don't want to say like they're not direct policies, because their policies are a little vague, but like their clinical morning sheet. It's a preset sheet, and facilities add to it based on their survey history. But as long as you follow that stuff, you're hitting every area that you need to, as long as you're reviewing it like you should.
Okay.
And the same thing like with their standards of care meetings, they do weekly, wounds, nutrition, falls, all of that stuff. If you stay on top of that stuff, you're going to do well.
And so do you guys, because I know as far as with my previous management experience, you have like weekly or like Medicare meetings, care conference meetings, and updating care plans. Like usually, I think it's like every 90 days, or depending on the resolved issues and stuff when it comes to updating care plans.
MDS will usually do, like we do their baseline on admission.
Okay.
And then quarterly, we do a quarterly assessment. It's an assessment form that we fill out, and then MDS goes through and does the big care plan over review.
Okay.
But you're responsible for like the small thing. I don't mean small. I mean like the daily things, like if somebody falls, updating their care plan.
Updating the care plan, the fall risk assessment, post falls, and all that kind of fun stuff.
You get a new order, for anticoagulant, it's going to be you putting it in.
Right, the new care plan for the coagulants and, blood pressures or CPAPs or,
new stuff like that. The infection nurse should do that.
Okay.
Wounds, the wound nurse should do that, but I always say, still it's your unit. Just because there's a wound nurse, you should know your wounds and stay on top of them.
Right.
And work together, where sometimes, I have another building that just had issues with wounds because they didn't take it as a team approach, and they just left, that's the wound nurse's job. That's the wound nurse's job. Unit managers weren't looking at the wounds, and like there was 4 different orders for the same wound. They forgot to DC some orders, but nobody paid attention because that's the wound nurse.
Yeah, no, I mean, I don't, because I myself, even though I am a unit manager, I assume that position because I still am an LPN. I still have that within my scope. I still have to look at the treatments to make sure everything's being done, or even like use my own assessment if that treatment being used is not healing, if it's not being done. Then I'll collaborate with the wound nurse saying, hey, because I'm like really by the book when it comes to, I like to follow wound nurses and see what they're doing as far as treatments, and if it's healing, if it's progressing, if it's not. And especially when it comes upon admission, usually admission, I always tell my nurses, since I was also an admission nurse, I tell my nurses, don't stage, because then that will set us up for failure, because you just say that you have to measure them, of course, but don't stage the pressure injury. Just say it's this length and width, and then just say where it is, but no staging. That's the wound nurse job. And then just make a treatment and put it in a doctor's note. And I'm very detail oriented as far as when it comes to admissions, so I always take it upon myself. I'm very big on skin assessments because a lot of skin sweeps are missed, and that's how that even looking under heels, like flipping, like it's almost treating the whole body like a pancake.
Head,
You gotta flip everybody upside down, and people are like, is this really necessary? Absolutely, it's really necessary. I know it's uncomfortable, but I have to see every area of your body, including your armpits. So, and it's necessary because a lot of things are missed.
Yep. Do and like further, you know, like once you get in the position, and I know right now they have a wound nurse, but they do open up like every now and then we have like a wound class where you can, you know, they'll let unit managers, if you're interested in getting wound certified.
I'm actually looking right now. I have a tab open on my laptop at home. I wanted to get wound certified. It costs like $200 though.
Oh yeah, yep. No, they pay for it.
Oh yeah, that's something I wanted to do, to get certified in wound care.
Yeah. So usually, I know they had one that's just coming up in February, so you wouldn't make it because I think they're cut off line. But I think in the fall again they offer too. So
that's something I would definitely be interested. And also another one that I wanted to do is, I know you have an infection prevention nurse already. That's something I wanted to get certified into as well, to add on. Yeah,
no, that would be great because, you know, it takes a team just because you don't have the nurse. And actually what they do for their certification, just if you're interested in it, and, you know, I lead a boring life, so I read and work at home all the time. But if you go to the CDC website, it's like CDC Train. If you type in CDC Train Infection Control, it's a free course from the CDC, and it's like 35 hours. I mean, you do different tasks, you know, it'll take you a little bit.
I think I was looking at my previous DON, and I told her, you know, because the previous building I was at, they didn't have an infection prevention nurse. I was like, that's something I was looking to actually taking, you know, and I was like, I'm interested in doing that. They didn't have a wound care nurse. They didn't have an infection prevention. The ADON wasn't really doing much. I was like, well, maybe if she was like, if I could take some of that off her plate, I could actually get certified. So it's like, really? Like, yeah, really. I'm like, that's the stuff I'm always trying to look for ways to enhance myself as a nurse and become better. What else I can do, you know?
Yeah, and definitely, because like I said, it's a team approach. Just because there's one don't mean we all can't, you know, you got to work together.
Exactly. You don't, I mean, just maybe on one day that wound nurse is like, oh, I can't today, I'm swamped, I have this going on, can you jump in? Absolutely. Just tell me where you want me to jump off, I'll give you my notes and stuff. And like, I want to make sure that we do everything on the same page and do things that she would like, you know. So instead of like kind of winging it and doing it my way, I want to make sure that we're both okay with how we do things.
Yeah, that's great. That's awesome. Any other questions?
It's not a major thing, but like, would I have a shared office with another manager or?
Right now, I know that Jesse had just mentioned to me last week they were going to do some office moves, so I'm not really sure. Right now, it would be shared.
Okay.
But I don't know how that she was talking about doing some office moves, so I couldn't even tell you where at the moment.
Okay. And I think what else? I wanted to ask about like the on-call rotation schedule. How does that really work?
So it rotates through all of you. So there'll be 3 unit managers and Jesse in that call, because the treatment nurse, actually their IP nurse takes it too. So 3, it'll rotate through 5 of you.
Okay. And it's a weekend, correct?
Yes.
Okay.
I shouldn't say that because I know it does include weekend, yes.
Okay.
But I'm not sure if she does the week, so we'd have to clarify that with her.
Okay.
It might be for a week, but I'm not sure how she did that.
And the last time I talked to Jessie, she said that only the DON and the administrator would have remote access to PCC.
Yeah, that's sad. Yes.
That was weird because my last management, we always had remote access, so I could always, which was, you know, kind of nice maybe that I could actually turn my brain off when I got home. But then, you know, I can't really, I'm just so used to printing out my daily reports at home, and then that way I get to work and I already know what my unit looks like.
Yeah, I agree with that, but that's a higher above us decision. And
okay.
they are, I laughed when I came with Medilodge because even like they're signing into PCC and getting in their systems, I always say it's like Fort Knox.
Oh, okay.
Yeah, so, yep, don't see that changing. I know everybody has complained, and sadly, they don't let you have remote access.
Oh, okay. Well, I mean, that's good and bad in a way. So, I mean, I guess when I'm done for the day, then I'm really done for the day. I can't really look at the schedule, so.
Yeah. And you're familiar with PCC?
Oh, very familiar, yeah.
Okay. Yeah. That's what we do, PCC, and then the wounds are on PCC as well.
Okay.
Infection goes through a different program. It's called Health Connects. But like I said,
and your X-ray is through MobileX?
Trident.
Trident, okay. And you still have access, and you have like a Pyxis, right? For like.
Yeah.
Okay.
Yeah.
And your pharmacy?
They're actually going to be switching pharmacies. Right now it's Pharmerica.
Okay.
Oh, wait, I lied. It is FarmScript right now, and we are switching to Pharmerica.
Okay.
So your building, which would be Westwood, is due to switch April 1st.
Okay.
So they're going to be starting trainings here in March with switching all of that. Right now they're FarmScript.
And your providers are for which provider? Theoria. I think, I work with Theoria before? I can't remember if it's Theoria. Because I know the one I had right now is, they just currently switched in Optalis. I can't remember how many providers I've talked to, because in Optalis, I think we are through Pioneer Pharmacy, and then I think I worked with, I can't remember the provider group that I work with, so I can't remember, but so the they have like, the providers are in the building Monday through Friday?
Yes.
Okay.
Yep. You'll have an NP in there. The doc comes in, I think, 3 times a week. On Mondays, they have Dr. Janice, who does their wounds, and he's the medical director.
Okay.
And then they have Dr. Ling, and then they have a couple different nurse practitioners there the other days.
Okay. And your pharmacy, you said, was?
Right now it's FarmScript, but April 1st it'll be Pharmerica.
Pharmerica in April 1st, right?
Mm-hmm.
Okay.
And we just switched to a new lab, so that's kind of a learning curve for everybody. It's called SureCare.
SureCare is your lab. Okay, so when it comes to like stat lab draws, do we do them or do we have to call out?
No, we do them and send them to the hospital. Usually I think Alpha will come pick them up.
Okay. Lab is SureCare, you said?
Yep.
Okay. All right. What else? I guess, and usually for if for the schedule or the staff, would I get like a list of like the full-time people and the on-call and the mandating schedule?
Oh yeah, they'll give you all that, and they actually have a scheduler person.
Okay.
Where that's her job, so you don't get pulled into that too much.
Okay.
Obviously, nursing-wise, if there's vacations or holes, or I think they're pretty well staffed right now, but, you go through, you kind of cycle if people quit, and there might be times where you might have to work the floor.
Right.
So they'll involve you on that. But
okay.
CQ is the name of the person that does the scheduling.
Okay.
So.
Okay. And like for team meetings, do you guys use Teams as a chat?
Yes, sometimes we do Teams. Like you're not really going to be involved in ops, but yeah, they'll do Teams for certain things. But
and then usually it's like for PCC, for important stuff, is it usually through Tiger Text on PCCs?
They don't have Tiger Text.
They don't. Wow. Okay.
No. For the nurses, they do have. It's not Tiger Text, but it's a different app you can go through. I think it's called Chat Easy.
Okay. And is it like secured? Is it like?
Yes.
Okay.
Yep.
It's encrypted too.
Yep.
Okay.
Yeah, and it's just with the doctors, and it doesn't stay, like, it's not part of the record.
Okay.
So it's, I've seen that in that building where a nurse has thought, oh, well, I notified the doctor this, and I'm like, when did you notify them?
Yeah, when did you notify them? Because I didn't notify them.
This, and I'm like, you do realize that's not part of the record.
Right.
So when I'm charting, I see nothing.
Right. It's almost like Snapchat where you send a chat and it's gone.
Yes.
Yeah. So, okay, so I guess that's going to be a new thing that I'm going to have to learn probably, since...
I think it's similar to the way it looked similar to I've worked with the Tiger Text before, and I did get access, like I said, to this chat easy when this nurse was telling me what she documented there. It's just you kind of, instead of going through PCC, there's a different system that you get into.
Right. It's just different because, I mean, everybody says, oh, just Tiger Text the physician. It's like, okay, I'll Tiger Text and I'll, like, loop in the managers, the floor nurses, and whoever's in charge. But then it doesn't get seen,
Yeah.
And it's like,
but
okay.
Tiger Text was nice, though, because you could create a nurse's note from it.
Right, exactly. And it's like,
and
okay.
This one you can't.
So, and that's the weird thing, because, I mean, I'm usually one of those people who's like, I sent that message, and if it's not responded to within, like, maybe 15, 30 minutes, and, it's, okay, did you see it? Or sometimes I have to run around the entire building, hey, I sent you a message, they didn't see it. It's like, okay.
Yeah.
So sometimes Tiger Text for me is not reliable. I'm the one who I have to go find you, and, of course, I have to... You wouldn't believe the stuff that I would have to tell nurses. If it's a stat emergency, don't Tiger Text. Please don't do that.
Exactly.
Please don't do that. So why would you do? If it's stat, if it's emergency, please don't do that. So, actually go find me, and I'll have to go use your legs and go find the doctor, please. Or go find me. Don't Tiger Text. Use your brain, please. Use your legs. So it's mind blowing sometimes, where it's like, I don't know how you're able to function here. Are you thinking it's emergency? Oh, well, just send a text. No, don't do that. So I don't understand. So that's one of the things I have to deal with. It's challenging, but then it's like, okay, so the hard conversations that I'm talking about, it's like, okay, listen, this is what's going on, this is what needs to happen.
Right. Yep.
So
but if you think of anything else, I'll give Jessie a call, and then you should, I'm sure you'll hear from her shortly. The minute I hang up, I'm sure she'll get you started and get everything set.
Yeah, I think that covers all my questions pretty much. It's like the on-call, the reports, and like the PCC access, and I think that's pretty much the questions that I have, which is it's convenient for me because I literally live 10 minutes down the road, so it's exactly what I'm looking for.
Oh, that's perfect.
It is, yeah, it's fantastic. So also the times that I'm supposed to be at the facility, it's usually 8 to 5, 9 to 6, because I know it stands up at 9.
It's usually like 8 to 5.
Okay.
And then, obviously if state's in the building, we don't leave until they leave.
Right. And usually state window show up usually around 7. You go in there earlier and you stay later.
Yep.
Yeah, I get that too.
Yeah, that week's torture.
It
or
is.
if they come in on complaints.
Oh, yeah.
Torture.
It's fun. Grievances are fun, always fun. Not fun, but fun. Then you get to do a lot of digging, so.
Yeah.
Yep, I've been there.
Yep, sure. But if you think of anything else after we hang up, you've got my number. You can text or call me anytime.
Perfect. Thank you so much.
All right. Well, you have a good day.
Thank you. Thank you so much for the opportunity. I'm looking forward to it.
No, me too. Thank you. I'm excited.
Me too. Thank you.
Have a good one.
You too.
Bye-bye.
Bye-bye.